Here are some benefits to the ARMS release technique. And again, ARMS stands for active release with manual stabilization. It can be used to treat any structural dysfunctions on any anatomical or sensory structure of the body. So if there is a structural dysfunction, remember we only release structural dysfunctions, and we need to determine whether something is a structural or a non-structural dysfunction by doing our active and passive range of motion testing. Then we will implement the ARMS release technique, and it can be used to release bone, joint, muscle, fascia, nerve, viscera, etc., skin, any type of structural dysfunction in the body. There are also multiple options for hand placement of our stabilizing hand. And what that means is that if there is an area that a patient is sensitive, or there is an open wound or a recent scar or that kind of thing, we're not going to want to place our hand there to stabilize, even though we know that that is a known point of injury. But we can then stabilize on the opposite or the lateral medial side of that particular area, provided that it does not provide discomfort to the patient. It involves the patient in treatment. So the patient is not just laying there while they're being tortured by a manual therapist. They are involved because they are then going to provide the movement that elicits the mobilization. And not only are they involved, but they're also in control, meaning that a person will not do anything that is going to elicit self-harm. So they are in control of the amplitude of the motion or the movement, and therefore they are less likely to do anything that would be harmful to themselves. And I have not ever harmed a patient using this technique. It doesn't require cognitive thought by the patient. We're just asking them to move. They don't really need to process. Even a patient with dementia can follow a simple command. Or if the patient is unconscious, we could use the CPM or an assistant or an aide to help us to move the patient, so they don't necessarily have to be conscious of the treatment. It releases tissue in less than 10 seconds. If you don't elicit a release in 10 seconds, I ask that you change your hand placement and try again, because you're probably either not on the structural dysfunction in the correct direction, or you're choosing the wrong point to stabilize. It's also less painful than most release techniques, such as functional mobilization or Rolfing. Can be very, very uncomfortable to the patient, and they cannot handle it. And I've even developed some techniques using the arms with the patient involved that can even make it less uncomfortable for the patient during the treatment time. And lastly, just as far as logistics are concerned, you could build this technique with almost any CPT code. So because it involves active motion, we could bill for Therex 97110. Because we're doing stabilization, that could be neuromuscular re-education 97112. We're doing mobilization, so that's 97140. If we're doing a motion that is a functional activity like squatting, then we can bill 97530. And if we're doing it with a walking technique, we can bill it under gait training 97116. So almost any CPT code can be represented by the arms release technique. And certain insurance companies now are deducting PTs for billing too many codes of 97110 compared to the rest of the geographical area, et cetera, et cetera. So this is a good way to ethically avoid that problem. So using the ARMS technique, again, we use them for structural dysfunctions only. How do we figure out where we're going to mobilize? This is where we go back to our diagnostic motion evaluation, DME, or our static motion evaluation. Both are used to determine structural dysfunctions. With our diagnostic motion evaluation, again, we will notice structural dysfunctions when they present themselves with passive range of motion. Remember, we need to test passive range of motion. When we're doing static motion evaluation, well, then we are passively moving the patient. So that is going to show us structural dysfunctions only. So once we find the anatomical area that did not present with a smooth, coordinated, even motion, that non-domino motion, or a compensation occurring elsewhere through the kinetic chain to allow that motion to occur, that is going to be the area where we're going to start our mobilization. Remember, if we are in the open chain, we're going to begin our observation distal, going to proximal, and it's going to be distal to the soft tissue structures that cover that joint involved in the motion. So if we're starting with ankle dorsiflexion in the open chain, we're going to start our observation at the toes. If we're doing closed chain, it's proximal to distal. So if we're observing closed chain dorsiflexion, we're going to begin our observation just proximal to the knee. At that point, we are now going to palpate, and it is important to palpate using your body weight, not your fingers rubbing into the fascia and the tissue, but using a firm force through your body into the tissue. That will help you to feel. If you're using muscles outside of the center of the body to palpate, it creates some sort of interference in your ability to feel what the tissue quality is underneath your fingers. This is so important with regard to palpation. You're going to palpate circumferentially around that area because, again, with diagnostic motion evaluation and static motion evaluation, once we decide the region where we think that dysfunction is located structurally, it could be medial, it could be lateral, it could be anterior, it could be posterior, it could be multiple places. So we are going to want to palpate entirely around that structure. So let's just say that I'm suspecting that there is a dysfunction at the proximal metatarsals, where oftentimes there are an open chain dorsiflexion. I will palpate the dorsum of the foot at metatarsal 1, 2, 3, 4, and 5, as well as the underside of the foot 1, 2, 3, 4, and 5 to feel for my structural dysfunctions. Now, not only am I going to palpate the metatarsals, the bones themselves, but I'm also going to palpate the tissue in between the bones. So it is very important that you become skilled at palpation. Now, if you cannot feel, we have other options to address when we're doing this. If you cannot feel for the structural dysfunction, which we consider to be a hard end feel, you will look at the ability of your mobilizing implement, usually your fingers. Is it able to sink into the tissue? If it is able to sink, then that is not a hard end feel. But if your mobilizing implement does not sink, then that would indicate a hard end feel. We call that sinkage. And if that doesn't work for you either, you can ask your patient to express to you the area of sensitivity or pain as you are doing your palpation. Okay, so we have three different options here. When we're identifying your dysfunctional tissue, you can either feel for it, so you'll feel for a hard end feel, look for it, okay, does my fingers or mobilizing implement sink into the tissue, or ask your patient to tell you where your palpation is tender or painful. Okay, so if it has a hard end feel, that's it. If you don't have sinkage, then that's it. If you're painful, if your patient gives you the positive squinch test, meaning ouch, or they try to hit you, then that's it. You have now located your dysfunctional tissue. Okay, so now you've found your structural dysfunction. That's just the beginning of the ARMS technique. So in this picture, structural dysfunction is located right in the middle. At this point, what you're going to do is you're going to maintain your pressure. I'm going to repeat that. You need to maintain your pressure of the depth into the tissue of the hard end feel, and then go around an imaginary clock or kind of scour that area to figure out where there is the hardest end feel, the least amount of sinkage, or the most painful direction for your patient. Now, in this example, I've picked that it is in the 2 o'clock direction as indicated by in red with the letter D. Now, you're going to keep that direction and depth of that hard end feel, okay, or area with the least amount of sinkage or area that is most painful, and take your stabilizing hand and determine whether your diagonal direction is either away or toward that dysfunction, okay? So it could also be on the same side as your mobilizing hands, or it can be on the opposite side of the body. Again, it does not need to be nearby that structural dysfunction. You want to think about placing that stabilized hand in an area that is known to be unstable. So if I have a patient with a sprained ankle, for example, I will stabilize at the ankle and maybe mobilize at the metatarsals if I'm finding a structural dysfunction at that area. So let's take a look at how we would do the arms release technique on an actual patient. You may recognize this photo from one of the previous lessons, but I had talked about how it does not appear that this individual is extending or going into dorsiflexion at his metatarsals. He's getting all of his dorsiflexion from his toes. In addition, he is then compensating with knee flexion. So again, using diagnostic motion evaluation, we're seeing that the movement is not fluid. It stops right here. You can see it by the wrinkles. And he is also compensating. So it fulfills both criteria of showing us a dysfunction. Now, do we know whether this is a structural or a non-structural dysfunction from the picture? The answer is we don't, but we're going to assume that it is a structural dysfunction. And again, how would I have determined whether it was a structural or non-structural dysfunction? I hope you're saying by doing passive range of motion. So I would have done passive range of motion, and I am going to suspect that my inclination was correct. I will see a bending of the knee and an inability or a stiff movement right here after we go into toe extension. So when I palpate those metatarsals going into dorsiflexion, I would see knee bending, the compensation, as well as the hard end feel. At this point, I don't know whether the structural dysfunction is on the dorsum of the foot, the side of the foot, or the underside, the plantar surface of the foot. So I will have to take my thumb and palpate passively into each area of the metatarsals as well as the tissue surrounding it around the side to find my structural dysfunction. So let's say I find my structural dysfunction right here at the fourth metatarsal. I then will go as deep as I feel the hard end feel, maintain that depth, and go around my imaginary clock to each direction to scour to feel for that hard end feel. I'm going to say that my direction is slightly up and toward 11 o'clock. I will then maintain my pressure and depth in the direction of 11 o'clock, and I am then going to take my stabilizing hand and pick an area known to be unstable. So I know that the toes are hypermobile because they're compensating for this lack of metatarsal dorsiflexion, but I'm also seeing a compensation at the knee. So I would then take my stabilizing hand either on the top of the knee or the calf area right around the knee or even the thigh, or I could go laterally, medially, or on the underside. And then I will take my hand with a flat surface. Since it's a broad area, I can use my entire hand, and I will sink into the tissue and apply a diagonal force either toward me or away, okay? Or go onto the top, toward or away. Or again, I can apply my force in the opposite direction, okay? So I'm going now from lateral to medial across that area as well. So I am going to, again, choose the direction that softens that hard end feel the most, maintain that force at the knee and at the metatarsals, and then have the patient move. A good movement would be toe flexion and extension, because I don't want to get gross movement at the foot where I might slip off of my mobilizing force. Nor would I want to do knee flexion extension and mess up my stabilizing force at that knee area. Again, you don't need to choose the knee if one, is not releasing your hard end feel, or two, let's say you're not it's awkward position for you. You can choose your stabilizing force closer to the dysfunctional tissue, maybe at the lower calf. Again, the arms release technique offers you many different options for mobilization.
So again, we can see that the toes are extended and the knee is bent. And what we're going to do is we're going to suspect that there's a dysfunction along these metatarsal phalangeal joints. So I will need to palpate using my body weight this way and around. And I find the hardest end feel is here. And what I will go ahead and do is I will go around my imaginary clock, maintaining my pressure. Here, 1, 2, and the direction is here. I will then stabilize the knee in an extended position. I don't want him to compensate, getting my forearm in the right directions, and have him flex and extend the toes. And extend. Good. And relax, and now increase your dorsiflexion. Pull the leg back, try not to use the toes, and see, less compensation of the knee, increased dorsiflexion, less toes.
So we're going to review the steps of the arms release technique, and I know there seems to be a lot of steps and it moves very slowly when I explain it, but as you get better at doing the technique, it's only going to take a couple of seconds for you to go through all of the steps in your head. First, we need to identify the location of the dysfunction using passive range of motion, because passive range of motion will show us structural dysfunctions, and we only use the arms release technique for structural dysfunctions. At the point that we know the level of the dysfunction, again, that point on the equator or the latitude, we're going to palpate around that entire area until we find the hard end feel, the least amount of sinkage, or the area that is most uncomfortable for our patient. When we then identify that structure by doing what I just said, looking, feeling, or asking, or maybe doing a little bit of both. Sometimes I'll feel something that's a hard end feel, and then I'll feel another one, and I'll ask the patient, which is more tender, this way or this way, when I am doing my palpation. Next, we're going to determine the direction of the hardest end feel. So we do that scouring around the clock. Remember, do not lose the depth of your pressure with your mobilizing implement or your finger. At that point, again, we're going to feel, look, and ask for the direction that is either the hardest end feel, the least amount of sinkage or movement, and or the most painful for your patient. At that point, you maintain that position. You're done with your mobilizing hand. You keep it there, and now you take your stabilizing hand, go to an area that is known to be hypermobile or inflamed, and take that hand, sink into the skin, apply a diagonal force either toward or away on a diagonal, okay, to feel for a release or an easing of that structural dysfunction. When you have found it, now just ask the patient to move in a manner that will not disrupt your hand placement, but will elicit movement over the tissues of the area that you are mobilizing. Again, in our example, toe flexion and extension was really the wisest choice.
For this lab, we'll need a couple of pieces of equipment to help us out. Simply, we could just take a pillow, place it on the floor, place one foot kneeling, and then work on the other foot in the kneeling position. Or if you prefer, take a step stool and bring it over, and you could have one foot up on the step stool and then working with the other hands. If you're in this position though, make sure you have something sturdy to grab onto in case you lose your balance. In demonstrating the arms release technique, we're going to demonstrate on our own bodies so that we get the sensation of what it feels like to have dysfunctional tissue as well as to stabilize that tissue and feel a release. So I'm going to choose some of the most common areas of structural dysfunctions in the human's foot. And the first one is right in between the first and second metatarsal. If you were wearing a pair of flip-flops, it would be where that tongue would go. So you're going to take your mobilizing implement, which is your thumb, and I should say that the position of the hand should be where that joint is being supported by the knuckle underneath. With your body weight, again, we're going to sink in to the tissue to feel for a hard end feel. Because it's our own body, we can feel tenderness, and we can also look for the ability of the tissues to sink. That has pretty good sinkage right there, but this tissue right here did not. At this point, I've found my structural dysfunction, I'm maintaining the depth, and I will go around my imaginary clock to find the direction that is the hardest end feel, the least amount of movement, or the most painful. And I'm feeling that although this is a hard end feel, this 11 o'clock position is the most uncomfortable. I'll now take my stabilizing hand, which is purple, and find a position to stabilize. Now I've sprained both ankles, so I am going to choose my ankle as an area to stabilize to feel the release of this tissue. Here's my diagonal position. I will dent the skin and go toward the foot. Now that actually makes it hurt more, or away. And neither of those positions makes it release for me. So now I'm going to try a different position, and I will go down toward the floor or up toward me. Neither of those release it either. So now I'm going to switch and choose a different location. I'll go to the dorsum of the foot, pull toward, that does not make it better, away does finally release that hard end feel, which was really hurting me. And now I need to move about my mobilizing implement. So what I'm going to do, the easiest thing for me to do is to bend my knee and come forward in a lunge and back. And bend and go forward and come back. And again, notice I'm able to gain more range each time because it's starting to loosen up. And last one. Very nice. So now as I go up, I feel not such a hard end feel. I have another one right on that first metatarsal, a little bit beyond it, a little bit more proximal. Again, I will scour around, and you should be doing this with me. Again, I find the position is a little bit more toward 12 o'clock, straight ahead. I'm going to use my same stabilizing position since it worked earlier, away from my body. And now I can change my movement. I can move my toes up and down in this position. That's another option for me. And I feel the release. The second position that I'm going to go to is at the navicular. And the navicular, even with people with flat feet, will often be restricted. So I'm on the navicular and I'm going to palpate down, and that is a very hard, painful end feel. Or up. Up, you can see, moves. Whereas down, very hard end feel. I'll again scour my direction around my imaginary clock to find the hardest end feel. And if this is, it's about 7 o'clock right there, down into this direction. So again, I have my mobilizing hand right here, stabilizing hand. I might choose that same position across the dorsum of the foot away, seem to make me feel better. So again, I'll get my forearm in the diagonal as best possible, dent the skin with my stabilizing hand. I am not changing the force on my thumb. I feel the release, and now I can move my leg out from side to side to feel for that release of tissue. Once that hard end feel goes away, then you are done. Another frequently restricted structure of the foot are the medial cuneiforms. So again, that's at the top of the foot, and I will feel with my hand across the medial cuneiforms for the hardest end feel using my body weight. And I find it to be right here. Again, I will go toward 12, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. And I found 4 o'clock. See, I have barely any movement right there to be the hardest end feel. So let's say with my stabilizing hands, I said that sometimes you should do a known area of inflammation. Let's say I had a bunion here. I could go on that bunion. Again, I want my forearm in the diagonal, or at least the finger. I'll dent the skin. I'm going to pull away. That does not make it loosen or less comfortable. And go in the away direction, and that makes it better. And again, I can move over my mobilizing hand by coming forward into closed chain dorsiflexion. And we'll do 2 more structures. The talus. The talus is restricted on almost every human being, and it's so important to mobilize because dorsiflexion is so important to function. So the talus is going to be just medial or in between the fibula and the tibia. So I found my tibia, and now I will palpate just lateral to it and come across to the fibula. And my hard end feel and my painful area is right around here. So again, I will go around the clock to 6, 7, 8, 9, 10, 11, 12, 1, 2, 3, 4, 5. 5 is the hardest end feel. And I will again stabilize. Let's try the ankle. Here's my diagonal. I dent the skin. I pull toward, and that makes it better. And now again, I can move my toes up and down to flexion and extension until that dysfunction releases. The last one we're going to do is the talus just underneath the tibia. This area oftentimes will stick out, the talus will, to compensate for a lack of weight bearing onto the first ray. It's one of the compensations of a flat foot. So right underneath the tibia, I will palpate toward the center. And if you noticed, I had the least amount of movement right there. I'll find my direction by going around the clock of the hardest end feel, the area that's most painful or the least amount of sinkage. And I'm feeling that it is 6 o'clock, straight down. My stabilizing hand goes across the dorsum of the foot, and I'll go away, which seemed to help, but this time it doesn't. So I'll try toward. That releases the hard end feel, and I can go into relative plantar flexion in the closed chain, going backward. And I feel my release.
Some final things that I want to talk about with regard to the arms release technique to remember is that since inflammation or trauma equals instability, a good choice for your stabilizing hand position would be in an area that is known to have experienced trauma. So if there's an old surgery, if there's an old injury, if there's some sort of itis going around in that foot, then that would be a great place to choose. Remember, alignment also equals instability because of the length tension ratio. So if you see a known alignment problem like a bunion or hammer toes, that would be another choice that you could choose for your stabilizing hand. Secondly, I mentioned this before, if a release does not occur within 10 repetitions of the patient's movement, then you can either change the movement pattern, double check your mobilizing position, making sure that you are in the direction of the hardest and feel the least amount of sinkage or the most uncomfortable for the patient, or change your hands, your stabilizing hands placement, move to another area, again choosing one that might have a known area that has been inflamed at some point now or in the past, or a known alignment issue.